Okay, people, here we are. Good morning, good morning, good morning. It's Wednesday morning. You have finished taking your farm test, and I'm recording the review for your next test. What a fabulous day it's going to be. I put on lipstick again. I got to make sure that I don't get it on my teeth, because then you'll be concentrating on that the whole time instead of what I'm saying. And this review is going to be extremely helpful. I would put out the word to people to look at this, because it organizes it a little bit better than the cluster that was just my lecture yesterday. Yeah, I don't feel good about that lecture. Anyway, so this is why we do reviews, to clarify things. Now, this is going to be a little bit of a different format today. So I'm going to pose a question to you, and I'm going to give you the answers. Yeah, I'm going to. Why? Because I love you. So these questions are not the questions on the test. Don't be confused about that. But when I ask the question, you should be able to answer it without looking at your notes. And if you can answer the question without looking at your notes, then guess what? You're prepared. Oh, and by the way, since I won't be talking to you before Halloween, happy Halloween. Yeah, I hope you have lots of tricks up your sleeve. Okay, here we go. So, what health assessment questions will the nurse ask about the patient's bowel habits? And what about their GI, about their eating, their appetites, that type of thing. So, be able to know what the health questions are. We discussed that pretty early in the lecture. So let's think about that for a minute. I'm giving you a couple of minutes. Actually, it'll be seconds to think about it. Write it down quickly. I think I'll get out my timer just so that I be sure to give you time to answer the questions, because they are so important. Timer. When we started, I won't do minutes. I'll only do seconds, I promise. I'm going to give you 30 seconds every time. How's that? Okay, I think that started for that. Just make sure that I still have it. Okay, did you ask about their appetite? Did you ask about any unexplained weight changes? Did you ask them about what medications they were on? Did you ask if they had any abdominal pain? And if they do, then Coldera. Did you ask if they took laxatives or herbs or enemas? Did you ask if they smoked? Yeah, you got to know that. You got to talk about that. And then did you ask if they traveled outside the United States? So these are the questions that you want to ask in a health assessment. Isn't that fun? Okay, so the next question I'm going to ask is, what effect does general anesthesia have on the bowel or the GI tract, whatever you want to call it? Ready, set, go. Okay, I lied. I only gave you 15 seconds for that, but it's only a one-word answer, so I hope you got it. And that it puts the bowel asleep. So really, do not expect any bowel sounds from the gut for the first 24 hours after surgery. All right? Okay, so there we go. The next question is, what gives stool its brown color? Go. Yeah, well, sorry, I didn't give you 15 seconds, but too bad, House. Again, it's only a one-word answer. And so bile. Bile gives the stool its brown color. So that being said, that if the liver, for whatever reason, is prevented from making bile or bilirubin, from getting into the stool, then there's something wrong with the liver itself. But remember also that it could be an obstruction of the common bile duct. And I have to tell you, and this is where I think I'm most concerned about the lecture yesterday, was that I didn't clarify that well enough. I told you that the bile backed up and that type of thing. But the problem is, as soon as a person's bile duct gets blocked, they are going to hurt, and they are going to hurt badly. And so they'll go in, they'll get it fixed surgically. And so it's not like there's going to be a huge engorgement like there would be with chronic liver failure, or the backup, the kind of backup that we were talking about when we were talking about cardiac failure, a right-sided cardiac failure. So it's not like it's going to prevent the liver. If the liver is making the bile and there's no way to get the bile into the duodenum, then what is going to happen here is that there's going to be severe pain, and there won't be this huge backup. And I think that that's what I was trying to explain to you, is that, okay, now you have this backup and engorgement in the liver, and I don't want you to think that anymore. Just nix that out, because if the liver's working, it's going to make the conjugated bile, or bilirubin, bilirubin. So the thing is that forget everything that I said yesterday about the backup. It was not correct. It was not correct. So just take that little portion and edit it right out of that little movie. And think about this, that if there is an occluded bile duct, there's going to be severe abdominal pain. A patient will have it surgically, the stone surgically removed, and then the bile will flow freely again, and there will be conjugated bile. So just remember, when the liver's working, there's going to be conjugated bile. When the liver is not working, then there's going to be free bilirubin. And one point that I wanted to make too, that I don't think I mentioned yesterday, was the fact that if the person is in liver failure, the liver doesn't make bile. You still have your bilirubin floating around because of the lysed red blood cells, but the bile, it quits making bile. Okay? Okay, I hope I clarified that for you. Okay, let's move on to the next question. And this one's going to take you 30 seconds because there's a lot of signs and symptoms that you want to be looking for. And that is, what are the signs and symptoms of GERD? Write down as many as you can remember. I'm hoping that you listened to the lecture before you're taking this little review. Oopsie, gave you that full time. Okay, so the thing, sorry, stop, pause, cancel. What is going on? I don't even know what's going on. Okay. All right, so the signs and symptoms of GERD, I'll stop with the clock, okay? I get it. Okay, so the signs and symptoms of GERD, dyspepsia. Now, you're going to have to know what these terms are, because you're going to see these terms in the test. So dyspepsia is what? I said that in the lecture, so we're not going to review that again. You need to go back and review if you don't know what it is. Regurgitation, coughing and hoarseness, hypersalivation, dysphagia, odonophagia, abdominal pain, belching, pyrosis, and globus. There you go, people. All right, let's move on here for just a minute. Okay, so lifestyle modifications for a person that has GERD, what are they going to be? First of all, they're going to eat 4 to 6 meals a day. Now, I had a student ask me one time, because I think on the slide it says small meals a day. And because that was not an option for a test question, then she did not choose this answer. But think about this. For a person that has GERD, they're going to do things. We don't want them to hyperextend the stomach. So they're going to eat 4 to 6 meals a day, but they're going to be very small meals. We want them to eliminate fatty foods, coffee, tea, chocolate, and spicy foods, because those stimulate gastric secretions. We want them to limit alcohol and tobacco, because that also stimulates stomach secretions. But as we learned from the master himself, Mark Richards, during lecture, the smoking and the use of tobacco will weaken the sphincter, the esophageal sphincter that enters into the stomach, and then it's going to allow more stomach content to come up through the esophagus. We are going to not eat. We're going to teach them not to eat for 2 to 3 hours before bedtime, so they can sleep and they won't be woken up in the middle of the night with heartburn. We want them to chew their food thoroughly, increase the head of bed. Why do you think they want to chew the food thoroughly? I really do think personally, that there won't be needed as many secretions to break down that food and turn it into chyme. If you have big old chunks of meat in there, then you are going to have to use more stomach secretions to get it to digest a little bit better. We want to raise the head of the bed for 1 to 2 hours after eating. We want to increase the head of the bed 6 to 12 inches to sleep. Now, remember, we never want them to lie flat. We want them to lose weight if they're obese and avoid straining. And again, why do we want them to lose weight if they're obese? Because you get a bigger stomach, and they eat more. And because they eat more, they develop this indigestion or heartburn. All right. If we have a person with GERD, what are some of their, what kind of precautions, I think I want to ask, do we take for a person with GERDs? You know, when I use the word precautions, safety precautions, fall precautions, aspiration precautions, yeah. I want to talk about aspiration here for just a minute. That those are the kind of precautions that you have to take when somebody has GERD. And so you need, and you learn this in fundamentals, what your aspiration precautions are. So go back and review that. Okay, so what does H. pylori cause? It causes gastric ulcers. Now, remember that we talked about 3 different kinds of ulcers yesterday. We talked about gastric ulcers, which are they are smaller and they're singular. And so remember, I showed you a little picture of where those gastric ulcers usually develop in the stomach. But they're usually small, they're usually singular. Does that mean that they're less dangerous? No. Because if that ulcer continues to erode the stomach wall, you're going to have a perforation there. We also talked about duodenal ulcers, and those are usually very deep. And then we talked about stress ulcers, which are usually multiple and they're very superficial. We did talk about esophageal ulcers, but those usually are at the distal end of the esophagus. Okay, interventions for persons that have stress ulcers. So you got to recognize that they need to reduce their stress, of course. But we will be giving them antacids such as Pepcid or any PPI or H2 blockers. We're going to avoid NSAIDs aspirin. Why? Because aspirin tends to eat away at the mucosal lining of the stomach. Alcohol, cigarettes, and caffeine. We are going to address their pain. We are going to avoid spicy foods. And we need to monitor for hemorrhage because, again, at any time that ulcer can perforate the lining of the stomach or wherever these little things develop. Okay, so a patient reports taking aspirin for arthritis for several months. What question will the nurse ask the patient? I'm trying to give you time to think about this. Use your critical thinking. This is what a nurse does when there's an abnormal finding. She wants to know why. He wants to know why. He will look and look and look until he finds the answer of what's causing the problem. Okay, so we want to ask them if they have any stomach trouble, if they have any abdominal pain. Because if there's any ulcers in there, there's going to be pain associated with that. And on top of that, we want to ask them if they've noticed any blood in their vomit or in their stool. Okay. So gastric ulcers start causing pains how long after eating? 1 to 2 hours. That's how long it takes to just, churn up the food in the stomach there. And so it happens pretty fast, but 1 to 2 hours afterwards. I mean, that's fast. But then duodenal ulcer, how long will it be before these people with a duodenal ulcer will start feeling pain? Think about it. Think about it. Usually 2 to 4 hours after eating. Now, why do you think it's longer for a duodenal ulcer to start causing pain than a gastric ulcer? It's because the duodenum is lower than the stomach where the gastric ulcer is developing. It takes longer to get through the stomach and then down into the duodenum. And so just picture in your mind the little picture of the intestinal, the gastrointestinal system that you had on the back of your quiz, and just recognize that the duodenum is lower than the stomach, so it's going to take longer. Yeah, I'm just telling you. 1 to 2 hours for gastric ulcers, 2 to 4 for duodenal ulcers. Okay, so we want to start thinking about the signs and symptoms of an acute GI bleed. Now, and this is one of the strategies I want you to implement in your test taking questions. Do you realize this is exam number 7? And we only have 11 exams in 1050. And so we are past the halfway point. So you should be starting to be very familiar with some of these signs and symptoms of the disease processes that we're talking about. And if you don't remember them from studying specifically for this lecture, you should really know this information just from past lectures where you talked about cardiac output and signs and symptoms of shock and lab values that would do that indication of an acute GI bleed. So I'll quit talking and I'll give you a second to think about it. First of all, with any acute GI bleed or any kind of bleed, you are going to have bright red blood. Lab value wise, you're going to have decreased hematocrit and hemoglobin, and you will have decreased blood pressure because of hypovolemia. You could potentially have a black tarry stool. If it's getting really, really low, the person is, or your blood levels are getting really low, you're going to become tachycardic. Because of low blood pressure, you may experience dizziness and syncope and vertigo. And of course, if it's really bad, then you're going to start having acute confusion. Okay, now let's compare that with the signs and symptoms of a chronic GI bleed. Again, you can potentially have melena. You can see bright red blood in the stool. But we're talking about GI bleed here, not necessarily ulcers. So think about this as somebody that has ulcerative colitis in the lower portion of the bowel. So the signs and symptoms of a chronic GI bleed could be bright red blood if it's in the lower portion of the rectum. Jody just pounded on the window and said hello. Hello. Anyway, so if the bleed is in the lower portion of the colon, you can have bright red stool in the toilet. If you have something like ulcerative colitis, which bleeds and then heals and bleeds and then heals. So it could be red blood, it could be melena. But if you're vomiting, then a chronic GI bleed is going to be brown coffee grounds. And like I said, the bright red blood and the melena as well. So what are the interventions that we want to do for a GI bleed? We do the ABCs, of course. We want to slap some oxygen on them. We want to monitor for shock and call the doctor. That's a fact, Jack. Okay, so what are some causes of acute gastritis? Remember, gastritis means the ulcer or the inflammation is going to be in the stomach. So you're looking at dietary indiscretions. Isn't that a good way of saying it? You overate. You went to Thanksgiving dinner and you filled your plate twice and then you had dessert. Okay? Okay. So dietary indiscretions are going to cause gastritis, but also food poisoning can. And we talked in the lecture, how fast do you start experiencing this nausea and vomiting from food poisoning? Yeah, it's 4 to 6 hours after, or 4 to 5 hours after. So it takes a little bit longer for the toxins to start making you go, ooh, I need to get rid of this. Okay, so what are the signs and symptoms going to be for a perforation of an ulcer and peritonitis? The number one thing they're going to have, or the first sign, is that they're going to have a very sudden, sharp pain. And remember, your phrenic nerve runs along the diaphragm. So if that happens, you're going to may have that pain that you're feeling in your stomach radiate up into your right shoulder. You're going to have vomiting. There may be abdominal tenderness. Again, there's going to be this abdominal rigidity there. And, you know, again, let's go back to this pain for just a minute. And that is, you know, a lot of times the patient's going to be doubled up into a fetal position because of the pain. Okay, let's see what else we can ask you. Okay, what is dumping syndrome? Okay, this is where the stomach contents move too fast into the duodenum. Now we've stretched out the duodenum a little bit, and we can't, it's not moving along as it should, and so it you have this bloating feeling there. There's also contributing to this feeling of bloatiness is that the food, it hasn't been totally digested, has this osmotic pressure pulling in more fluids from the tissues, and so you're going to have even more content in the duodenum. It's usually occurs a couple hours after, not a couple of hours. The early signs start about 30 to 60 minutes after ingestion of food, but then the advanced systems of dumping syndrome can take anywhere from from 90 minutes to 3 hours. So what are we going to do for dumping syndrome? Again, we come back. Notice this is the same things that you want to do for people that have GERD, and that is eat several small meals a day. Yes, so that your stomach, if it's puts it through the pyloric sphincter, that the duodenum doesn't get overloaded. You're going to have. Does that look better? It seems to me you won't be able to see up my nose when I pull in close. Anyway, so you have signs and symptoms of dumping syndrome, and then you want to eat. We moved on to interventions for dumping syndrome. So we'll have several small meals a day. We'll thicken our foods if we need to. And remember, with the gastric ulcers, we wanted the people to sit up in bed for an hour or two after meals. But with dumping syndrome, we do want them to lie down for an hour after meals to slow that migration of the chyme into the duodenum. We want to increase our complex proteins, and we want to increase our fiber intake. And we don't want to take any simple sugars. All right, then I show you those fabulous pictures of diverticulitis, if you remember, and the I think that it was losis. There didn't seem to be a lot of inflammation around that bowel picture that we saw of the colon and the diverticulum. That's a good word for it, don't you think? Anyway, so when there's multiple diverticula, then in the bowel, and there's no inflammation there, there's no redness around there, there's no infection, then it's diverticulosis. If it's litus, then those little pockets are going to get very, very inflamed because fecal matter have gotten caught in those little outpouchings, and that toxins from that fecal matter are starting to irritate the inside of those little outpouches, and they're going to it can begin the erosion process, which could eventually end up with a perforation. So how do we prevent exacerbations of diverticulitis? We're going to increase our fluid intake, and we're going to increase the amount of fiber that we have in the diet. Why? Because the bowel matter or the fecal matter is not soft. Then fiber will give it a solid formation that easily can, with peristalsis, move through the bowel. But if we eat high-fat foods, then it's going to be a real sticky type of see? Sorry, disruptions. It's going to be a real sticky stool, and so it will get caught up in those little outpouchings, which can eventually develop into diverticulitis. Okay, so when you have a person that has ulcerative colitis, and we talked about ulcerative colitis, that it was okay, I'm in trouble now. I've lost something. My cursor, I can't make my cursor go anywhere. Hello. we have to do this. There we go there. And then we want to come over here. Okay, I'm back where I should be now. Okay, so if you're doing a patient comes in and they've been diagnosed with ulcerative colitis, what do you think probably the most important question can be that the nurse can ask? I forget there's nobody listening. Anyway, you're going to ask them how many loose stools they've had in a day. Remember when we were talking about inflammatory diseases, namely diverticulosis and Crohn's disease and ulcerative colitis, I told you I differentiated between how many loose stools somebody with Crohn's disease is going to have as compared to somebody with ulcerative colitis. Crohn's disease, they're going to have 5 to 6 loose stools a day, but with ulcerative colitis, they can have 20 or more a day. So, and it's very, very uncomfortable. So, how do we want to prevent, not prevent, but what do we want to do for people that have ulcerative colitis? We want to eat a diet that is high in protein. We need to eat a diet that is high in calories because really the nutrient absorptions are going to happen in the small intestine, down in the lower intestine. There's not going to be any fluids absorbed. There's not going to be any fluids absorbed with Crohn's disease up in the small intestine. But that's going to happen with people with ulcerative colitis as well. So we want to keep them hydrated because you're at high risk for Crohn's disease or ulcerative colitis for dehydration. So we want to eat a diet high in calories. We want to omit milk products from the diet because that's going to cause gas, which is going to irritate. It's going to hurt as that gas bubble moves down the bowel. And then in times of that exacerbation, we don't want to take a high fiber diet because we don't want that hard stool coming up against, or firm stool coming up against the lumen of the colon, which can irritate it even more than it already is. Okay, then we just talked a little bit about gastric surgery. And so we want to make sure that we can recognize any signs and symptoms of hemorrhage after surgery because it's a major surgery. It's a major surgery. Yes, they can do some surgical measures laparoscopically, but if you're having to cut through the abdominal wall and its muscles and everything like that, and then you go in and you're opening up the bowel for whatever reason, you are going to end up with gastric secretions, or not gastric secretions, but fecal secretions, fecal drainage that's going to enter the peritoneum. And so you're going to be at high risk for infection or for hemorrhage because, there is so much that you're dealing with. It is the most amazing thing in the whole wide world when you are seeing an abdominal surgery because they literally take out all your guts. They do. They take them out, they open up the abdomen, and they start pulling out the intestines, and they'll put them in a Ziploc bag type of thing that is taped to the abdominal wall of the patient. So they pile them all into the intestine or into these Ziploc bags to keep them out of the way while they're working inside the abdomen. And they put some moist gauze pad in there to keep them nice and moist. And then when they're through with the surgery, or if they are looking for a perforation of the bowel. And anyway, they start going piece by piece of this 25 feet of intestine. They're looking for what they need to do. But it's a very intense surgery. It's very meticulous surgery that they have to do. And so because you have disrupted all of this stuff, and if you've had to resection the bowel, you've cut the bowel into different places, there's just a huge, if you don't stitch up every little nick or nanny, you can really run the risk of internal hemorrhage. So we've got to always look for hemorrhage after some kind of gastric surgery. So for the first 24 hours, there should be a scant, bloody amount of drainage on the dressing, but we need to start being concerned or look for further evidence if we suspect internal hemorrhage. So what we're going to look for is gastric distension. And so, again, one of the things that we have to monitor for is there gastric distension? Do you see that the abdomen is larger than it was prior to going into surgery? And we want to attach suction to prevent any kind of pressure, because if the abdomen was open during the surgery, and so when the doctor sutured it up, there was no distension there. It was where the body naturally came together. Now, if there's hemorrhaging, if there's a peritonitis, there's going to be swelling in there. So there's going to put that tension on that surgical incision, which can cause a dehiscence. And so I am doing a conference. Okay. And then you want to assess the dressing and assess for any black tarry stools or any bloody vomit, that type of thing. All right. We're going to talk a little bit about cirrhosis of the liver or liver failure. Don't forget that the number one cause of that in the United States is alcoholism. But there are different kinds of cirrhosis. And cirrhosis is where those little hepatocytes have nodulized, they have calcified, and they can no longer do what they're supposed to do. I had a picture, go back and look at your picture in the lecture and see the difference between a normal liver, a functioning liver, and a cirrhosed liver, because there's just nodules everywhere. And wherever there's a nodule, you now have a hepatocyte or multiple hepatocytes that are forming that nodule that are no longer working, and so they can't do what they need to do. And then we have biliary cirrhosis. Okay, you say it. I don't care. I know it's not right. So biliary, it sounds like there's too many biliary. No, that's too many L's. Biliary. It's a chronic obstruction of the bile duct. Okay, the common bile duct is obstructed, either with a gallstone. It's mostly a gallstone, but a tumor can be a tumor. So that can also cause cirrhosis as well. Why? Because you've got this backup of bile. There you go. So let's talk about the signs and symptoms for cirrhosis of the liver. First of all, you're going to be jaundice. And what is the lab value for somebody that has jaundice? When the bilirubin is going to be greater than 2.5 milligrams. All right? So that's greater than 2.5 milligrams. Also, remember, these bile salts will start permeating. They're not being excreted, and so they start permeating the tissues and causes just this incessant itching, which can cause a person to bleed, and encephalopathy. They may also exhibit a decreased immune function by having leukopenia, thrombocytopenia, or anemia. The person's going to have edema. And then there's those little hormone problems. For men, it's gynecomastia. Gynecomastia. There you go. Say that 3 times before your morning coffee. There's a decrease in pubic hair. There's atrophy of the testicles. I can say that. I can say that word without blushing. Pardon me? Who said that? Chelsea.
It's Chelsea.
Hey, Chelsea. I'm just doing this as a review. You guys.
I know. We had 5 minutes before class started, so I hopped on.
Good for you. So you can hear me okay? I'm so sorry if you have to.
Nope, you're great.
Okay. All right. Now just wait till you can hear this in full. You'll put a gun to your head. Okay. So, and the women are going to have amenorrhea. Okay. So we talked about 2 causes of heart failure. We talked about hepatocyte failure, where the hepatocytes themselves are no longer doing their jobs. And we talked about portal hypertension. So let's talk about the portal hypertension for a minute. What are the signs and symptoms of portal hypertension? Again, I'm giving you a few seconds so you can think about it without having to look at your notes. Okay, so with portal hypertension, the person's going to have ascites. Remember that beautiful vision in your mind, a picture of that man's stomach. Yeah, that's how much literally fluid can build up in the abdomen in a 24-hour period. And they may get rid of it through paracentesis, or they can get rid of it through diuretics. The patient is also going to have the splenomegaly and very enlarged spleen. And that's why the person is going to end up with leukopenia, thrombocytopenia, or anemia, because the spleen isn't doing its job. So an enlarged spleen and then esophageal varices. So this is really a severe complication, a very dangerous complication for a person that has portal hypertension is esophageal varices, because the esophagus is so fragile. So you have these engorged veins within the esophagus. And all you have to do is eat a piece of steak. It is, it's chewed up. It's not digested yet. So it's very fibrous here and it's going down. Or you can have a chip. Or you can have very spicy foods that irritate the lining of the esophagus. It doesn't matter. Whatever happens, and it's going to cause that vein to either be lacerated, or it's going to puncture that vein, or it's just going to erode the lining of the esophagus. Whatever, that vein is now bleeding, and that is an esophageal varice. You're going to have bright red emesis. Now, the thing about it is, if it's a slow leak, not large, but if it's a slow leak, then the blood will go into the stomach. Maybe the patient doesn't even notice it, but will ultimately end up with what? Melanoma. Yeah. So because that blood will travel through the digestive tract, past the duodenum into the intestines and work its way out. And so esophageal varices are dangerous in that respect, is that if it's a slow bleed, nobody's noticing it. But if it's that vein bursts, then there's going to be a significant blood loss. And so the person, and it's very difficult to get that blood to stop because it's internal and it's difficult to get to. And so person can become hypovolemic and go into shock pretty quickly if there's a significant tear there. and of course, a deterioration in mental status. Okay, so what are we going to do for somebody that has esophageal varices? Now, this doesn't even mean that there's bleeding. Let's just say that they just have liver failure here, they have portal hypertension, they have esophageal varices. We're fine so far. What are we going to do to try and protect these varices from tearing open? Think about it, people. What would you do? Okay, we want them to eat very soft foods. Applesauce. Lots of applesauce. I don't know. I just chose applesauce. But we want them to eat soft foods so that nothing is eroding or causing an abrasion in the esophagus from that very fragile lining of the esophagus. Okay, so what are some interventions that we're going to do? We talked about what we're going to recommend the person to eat, but what are we going to do for a person that has...
You are currently the only person in this conference.
I know I'm the only person in the conference. So what are we going to do for somebody that has a bleed, an esophageal bleed? First of all, we put them on a vasopressin, which causes those vessels in the esophagus to constrict. There may be a banding, there may be a sclerotherapy where we inject an agent that thickens and closes the dilated vessels. We do want to put them on oxygen, of course, and we, of course, have to put them on risk for aspiration. And be prepared to transfuse blood if needed. So we would have the RN start some IVs. Because we start infusing fluids into the system, then we need to insert a urinary catheter so that we can have strict monitoring of urinary output to avoid fluid overload. I think I already told you that we had oxygen administration. Oh, yeah, and we also want to do vital signs. Got to have vital signs. Need to have vital signs. Anytime you're looking at blood loss, you need to have vital signs. Okay, so what are some of the signs and another complication that you're going to have of a GI bleed or an esophageal bleed is going to be hepatic encephalopathy. So what are some of the signs and symptoms of that? So it's always include looking at your serum ammonia levels. And then there's going to be some confusion because of in fact, that's what's going to notify you or give you a hint that there's some hepatic encephalopathy going on, is that there's a patient is experiencing. I'm looking at this guy standing on the top of a 10-foot ladder looking at the fire alarm. How do men stand on top of ladders and not fall over? I don't get it. Anyway, so one of the things that's going to alert you that there may be some encephalopathy developing is that the patient starts, there's a change in mental status and a person starts getting confused. And then don't also forget that asterisk that I taught you where you have the patient put their hands up like this, and then as a healthcare provider, you come and push against it. And if there is some nervous reaction to the ammonia levels, then there will start being tremors in the hands. I didn't do that tremor very well. Looks like I was waving. Sorry. I'm so sorry. Okay, so we talked about the different lab values that may indicate some hepatic disorder. We talked about elevated ALT, elevated AST, elevated ALP, elevated GGT, elevated bilirubin, and decreased albumin. Thank you. Thank you very much. I thought I named those off pretty good. Okay, so we talked about the person having ascites. person in liver failure is going to have ascites. So with their dietary modification, what do you think it's going to be? What kind of diet do you think they're going to be on? A low sodium diet. Yes. Remember, fluid follows sodium, water follows sodium. So we want a low sodium diet so that they don't retain any more fluid than is necessary. We will also put them on a diuretic. We talked about Lasix, which is a loop diuretic, and then we talked about aldactone or spirulactone is another word for aldactone, which is potassium-sparing diuretic. They're not going to have a lot of energy. Remember, they're going to be anemic, so they're going to be tired. We want to have them take daily weights. Why? Because daily weights are the best indicator of fluid retention. We want to take daily abdominal girth measurements. We want to monitor their fluid and electrolyte values, especially because if we're giving them diuretics, they're going to be peeing off a lot of fluid. And with every drop of that fluid goes a little bit of potassium. So we've got to monitor fluids. We got to monitor albumin levels. We need to record the I's and O's and know what a TIPS procedure is. There was a beautiful picture of that in the slide presentation. And we want to look at pain management, make sure that we administer any analgesics that have been ordered, and teach them some non-pharmacological pain relief measures. So make sure that you look at a person that has cirrhosis and look at the dietary guidelines for a person with cirrhosis. Okay, so what is obstructive jaundice? And that, by its very adjective, should tell you what is going on. The common bile duct is obstructed. No bile is going to go into the duodenum. That is obstructive jaundice. All right, interventions for obstructive jaundice and itchy skin. So again, this should be very clear to you from our skin, hair, and nails lecture. We want to avoid soap because it dries the skin, which can cause further itching. We want to avoid perfume lotions because they tend to dry out the skin. We want to use cool rather than warm water, and we want to use lotions that are not alcohol-based, and if necessarily, give them some Benadryl. Stop that itching. Okay, so we mentioned those lab values earlier. Where was it? That indicated it was a liver panel that indicates hepatic function. But now we've determined that there is some disruption, there is dysfunction of the liver there. So what is the liver in charge of? Most of the coagulation factors in the coagulation cascade. So now we know that they have a problem with bleeding. And so what are some of the lab values that we're going to look at for bleeding? PT, PTT, INR, and the bleeding time exactly. And then finally, we're going to look at the delegation. What can you do when you are caring for a patient that is in liver failure? And we need to recognize what we can delegate to a CNR, a CNA. I don't know why I say CNR. I have no idea what CNR stands for. I've never used that terminology before. So if you were going to delegate something to your CNA in caring for a patient with liver failure, what can they do? What can't they do? What do they need to notify you of that they saw to make you aware of something. Just think about those things that a CNA can do and delegate. That's it, my friends, my dear, dear little chicks. But just follow my big rear end as I waddle along. You're going to get through this. You are going to rock this. No, nay, you are going to score. You are going to just knock this out of the park. I have every confidence in you. Just think about these things. Everything should be, we're halfway through the semester now. Things should make total sense to you instead of just strict memorization. If you come across a question, make sure that you read carefully the verbiage in the question, that you're very sure of the patient that you're dealing with before you rush to decide what the options are, which option you want to choose. Make sure that you understand what the question is answering. And it can be as small as losis colitis that can determine the difference in the option that you would pick. So you slow down as one of your strategies going into this test. Slow down, because every option that you do choose should make total sense with the question that is being asked and the information, the data that you are collecting by reading the question. Okay, peeps. I'm saying goodbye, peace out, and have a fabulous, safe weekend.